Good afternoon and evening. Welcome to the Stanford Medicine Alumni Association's Alumni to Alumni Speaker Series. My name is Jennifer Cobble, and I'm the Executive Director of SMAA. This series features accomplished graduates of the Stanford School of Medicine as they share their knowledge and experience in a variety of healthcare, research, startup, and private sector settings. With these presentations, we hope you will gain a better understanding of the diversity, innovation, dedication, and impact of the many alumni who represent the Stanford medicine community as leaders in both medicine and the biosciences. Before we begin, I would like to remind you that your microphones and visual profiles have been set to listen-only mode. Only the speaker and moderator will be on your shared video screen. Once the presentation begins, if you want to make the speaker image larger, you can adjust it by putting your cursor between the speaker image and the slides, finding the double line, and then move your cursor right to left to enlarge or shrink the sizing. Should you encounter technical difficulties, please try leaving the webinar and then logging in again. If the issues persist, you can reach out to us at medalumni@stanford.edu, and one of our staff members will help you. Finally, we'll be taking questions at the end of the presentation, but you can submit questions anytime during the presentation by using the Q&A feature at the bottom of your screen. Do not use chat, use the Q&A feature. If you see a question similar to your own, you can like it by clicking on the thumbs up icon, and that question will move up in the priorities. Given our large audience, I regret that we can't ensure that all the questions will be answered in the time we have allotted. Now I'm pleased to begin our session, Virtual Care in a Post-COVID World, Threat versus Opportunity, with Dr. Ian Tong. Dr. Ian Tong is President and Chief Medical Officer of Doctor on Demand, a leading supplier of telemedicine and virtual patient care. He has spent his entire career working hard to improve access to high-quality care and has continued this work through his recent position where he's exploring the potential of technology and influencing a new and emerging area of medical care. In addition to his work with Doctor on Demand, Dr. Tong is a clinical assistant professor at Stanford University Medical School. Previously, he held multiple medical leadership roles, including being a former chief resident of internal medicine at Stanford Medicine. He was founder and medical director of Thrive, the health resource initiative for veterans everywhere, which was honored in 2008 with the Veterans Administration Secretary's Award for Outstanding Achievement in Service to Homeless Veterans. Additionally, he was co-medical director of the Arbor Free Clinic in Menlo Park, where he helped serve local communities in need. Ian is a national collegiate champion in rugby at the University of California at Berkeley, boo, and was named to the American team in 1994. He graduated from Berkeley with a BA in English. His medical degree is from the University of Chicago, Pritzker. He completed his residency in 2005 and served as chief resident of internal medicine in 2006, both at Stanford's hospitals and clinics. And from 2010 to 2016, Dr. Tong served on the Stanford Medicine Alumni Association Board of Governors. Please welcome Dr. Ian Tong.
Thank you, Jennifer. Thank you so much for that introduction, and I'll go ahead and share my screen with the group here. Just listening to you even go through that, it just reminds me of how fortunate I have been to to be able to walk the halls on the campus of Stanford and to become well acquainted and friends and colleagues with many of the faculty, my fellow residents who train with me, and then members of the Stanford Medical Alumni Association. So just been such an enriching experience for me. And so when Jennifer called after I'd worked with her for 6 years on the Alumni Association, as a resident representative, actually. And I think I might have been the first resident representative on that body. I was very excited to do this. And so anything that I can do to give back to the Stanford community, I am very happy to do that. But yes, it's true that I do have an undergraduate degree from a small public university across the Bay. Definitely want to thank you all for attending, and also thank my family, my friends, and the Medical Alumni Association for this opportunity. So really happy to talk to you a little bit about what we've been doing. I thought I should probably just give you all a little bit of quick background. I know Jennifer read a bit of a bio about me, but I did train at Stanford. From there, I was, as a chief resident, I was given the opportunity to join the faculty at Stanford, and then also take a job as medical director of Veterans Outreach at the VA Palo Alto. And the reason I'm mentioning that is because it was through that work that I actually was first introduced to telemedicine. So that's when I was early in my career. The VA had these telemedicine programs, and I began building telemedicine clinics for the VA, both for the rural health program, and then some work, I was trying to always see if I could improve outreach through telemedicine to the homeless veterans population. Really didn't have that much success. That was many years ago now. That was about 13 years ago that I began, and I was trying that. So when you think about that, that's really hearkening back to a time before we had smartphones and before all of us had really ever done a video visit. Maybe we had done a Skype visit, but that's very different from the technology platform that we are on now. And so I may talk a little bit about that in terms of background. What I consider myself now is really, I am an internist, but I feel like I do way more digital health and way more work in what's called digital health now than anything else. And so the reason I make that distinction is because I really think the world is changing quickly, and healthcare is evolving quickly, and digital health tools and the technological capabilities are changing our work environment. They're changing our workflows. And sometimes it's for the better. Technology is supposed to scale what we do and make it easier. But sometimes it's honestly, it can be for the worst. And I think in healthcare, a lot of times it's for the worst. So I'll talk a bit about that, or just try to give you all a few, comments, and, maybe provoke some thought around whether telemedicine and virtual care is an opportunity or a threat for our profession. So I just thought, I don't know what everyone's baseline is with telemedicine, or even your knowledge of what Doctor on Demand is. So I'll just say what Doctor on Demand is in a context of, as an example of one of these types of telehealth modalities. But telemedicine itself is really a subset of telehealth. A lot of people like to define them differently. What I would say is, they're really used interchangeably for the most part. So I like saying telemedicine because that's what I do more of, which is actually delivering clinical care, and our practice at Doctor on Demand. That's what we do. We essentially approximate an in-office encounter, right? A doctor-patient encounter, and we're just doing that through mobile devices or home computers, and allowing the doctor and the patient to meet virtually across distance. And so we're just using technology to do that. But again, it's really approximating a doctor-patient visit and relationship. And I think that's important to make sure that we include the relationship part of it. Telehealth is a broader category that includes course. If you were to do a course remotely, or we did a patient education session, and someone's doing a patient education with a diabetes educator, that may count more as like a telehealth modality rather than telemedicine. But for the purposes of this talk, I would say you can just use them interchangeably. To break this down in that blue column, what I'd say, there's really three, primary use cases for telemedicine for telemedicine. We'll leave telehealth on the side for a second. So for telemedicine, you have synchronous visits. So that's what we're doing now. If you were my patient and I was your doctor, or vice versa, we would be having a one-on-one interaction And that would be synchronous, right? In real time, we're having a face-to-face encounter, and it's a virtual visit, right? So that's when it's provider to patient, it's a virtual visit. When it's provider to provider, it may be a consultation between the doctors that are involved in the care of a patient. Could be like a curbside. So those are the types of interactions that I would say are the synchronous, what is referred to as clinical video telehealth, or CVT. The next category is remote patient monitoring. So this is the use of those wearable devices that are allowing you to get someone's weight at home, or maybe get their glucometer results, or continuous glucose monitoring. You're able to get that data asynchronously from the patient's home, or directly from the patient's body as it's being measured. And then those data endpoints are going up to the cloud and being stored in the cloud, or they're going to a dashboard somewhere that's being monitored by a healthcare professional, and then they're going to react to that data, and then they may outreach to the patient. The final modality that we're going to talk about, or that I'm just going to talk about and introduce today, is other asynchronous modalities that are called store and forward. And these are more traditional modalities, such as if you know the ability to message back and forth with a patient. This is becoming more popular now, where there is text-based therapy, for instance. There are a number of companies that do this, where the patient will text them how they're feeling, they will text back responses, and they'll essentially just have a text exchange. And it may not be in real time. Sometimes that might be minutes or even hours apart with responses. But the idea is to have an ongoing dialogue with the patient. More traditional asynchronous store and forward modalities would be teleradiology or teledermatology. So just giving you this rubric for thinking about, what kind of modality am I in, if you're really interested in some of the basics around telemedicine. But I think that probably the version of telemedicine that we're talking most about today, and I think that most of us, what we really think about, is the ability for a patient and a doctor to do a synchronous visit in real time. And that's what most of us have had experience with this year during this global pandemic. Next slide here is just talk about the product market fit. So as we were getting into, beginning our journey 7.5 years ago with Doctor On Demand, that clinical video telehealth or synchronous visit is primarily what we do. And so we had to really figure out quite a few things to be able to do that. As I mentioned, about 12 years ago, there was really the first iPhone, and that iPhone, 13 years ago, and that iPhone did not have a camera on it. So just think about how far we've come. When we launched in 2013, Doctor On Demand saw that there was massive uptake of mobile devices and smartphones. They did all have cameras on them. And the key point here was that they were actually using a platform called WebRTC. So WebRTC, to make that relatable to everybody, is Skype was not on WebRTC. The original Skype platform, if you'd ever done a video interaction through Skype on your computer, it was grainy. There might have been lag to what the patient was, or what the person was saying to you, and there was latency in that. And so the WebRTC platform is much more similar to FaceTime, Zoom. These are actually all on WebRTC platforms that's really given us the high quality, high definition, and real-time interaction that does not have the same level of latency or lag. And so what that's done is it's really improved the quality of service of these encounters, and you can actually have a really nice visit that allows you to actually develop a relationship with that individual, and it feels just like an in-person or a regular face-to-face visit. So the tech platform was a huge operational piece to figure out. We also had to find clinicians. We had to find a clinical workforce that was willing to do this, because you have to have capacity and deliver a service level that really is 10 times better than traditional care or the usual care experience that patients experience. And what we knew in our marketplace was that wait times for primary care were getting longer and longer, sometimes 3 weeks or 4 weeks for patients to get in to see their doctor. This led to the emergence of urgent cares, overutilization of the ER. And so we felt that there was a big opportunity through telemedicine to offer that incredible access to care same day. And we wanted to do it on demand, meaning we could staff that service and employ doctors who would be able to be available when the patient wanted them 24/7 every day of the year. The last piece we had to figure out on the operational side was demand. So you can build a service and you can put all the pieces in place and you can figure out the technology. And you can actually, if you look at the screens here, you can do all of the different pieces there as well on the apps to make sure that it looks great and it feels great, but if there's no patient demand for that service, then you're not going to go anywhere. There's really nothing to do, and nobody's really going to have awareness or get to experience all of the work that you put into building your platform. And so, so we had to experiment with demand. We first launched what's called D2C, direct to consumer. We then saw that we could quickly move to B2B and then B2B2C. And if there's time, I'll say more about those, or you guys can ask questions about those if you're interested in them. But they're really just different ways to approach and gather awareness of your service and members to your service so that they can experience it. Some of the other barriers, though, I mean, I was coming from a traditional bedside medicine career. I was really thinking, how do we recreate what happens at the bedside? And so I had to unlearn some of the things that I already thought that I knew about how healthcare had to be, how it had to be done, what the level of quality was. I honestly was concerned that there would be a degradation of the doctor-patient relationship, that patients would not feel it was high quality. So there was a lot of concerns about this at the outset and whether we'd be able to do it. Just to frame this up for how things felt at the very beginning, many years ago, was we were looking at Doctor on Demand is a 50-state practice. We were looking across multiple states to see, can we launch this service in individual states? And the reality was that at that time, many states did not allow for different versions of telemedicine. So we had to make sure that the state would welcome us. And so this is just an anecdote showing, we went into Alabama. I literally flew to Birmingham and then drove to Montgomery, Alabama to meet with their medical board and to present to them. I did this with our legal counsel. And so we knew going in there that Alabama had a huge primary care health shortage. I mean, we went in there very confident, feeling that, this is like one of the states that needs us. They really need our services. And so we were actually given a pretty rude awakening, especially myself, as when they called us up to speak in front of the entire medical board, the head of the medical board at that time, who was a physician, basically said, hold on a minute there, before you start, you see all those guys along the back row. He said, if they don't like what they hear, they're going to shoot you. And so I would just say that just gives you some idea of the, I mean, I'm sure he thought that was funny at the time, but obviously I did not, given knowing the context of where I was and the fact that I was from California. But it just gives you the idea of what the environment was like as we were launching and going to these different states. And the way that story ended was Alabama actually said, no, we're going to put you on probation. We hadn't done anything. We'd never had a visit there, but they said, we're going to put things on hold. And then a few months later, they did decide that they would welcome us as a telemedicine vendor within their state. There were a lot of other barriers, to be honest, that we were seeing in 2013. People did not have awareness of what we were doing, but there were also structural limitations that prevented us from really building out our business. So for instance, we could not offer care to Medicare recipients and in some cases, certain Medicaid recipients. And the reason why we could not do that was because there was a very strict requirement that there was an originating site. So patients had to go to a clinical site where there was telemedicine equipment, and then they had to work with a technician who would then hook them up to a doctor who was at a remote site, and then the doctor could see them. And so you could see how that already was a huge barrier to entry for patients to have to go to another, it didn't really eliminate the barriers to care for them. They just had to go to a clinical site so that they could access a doctor who was remote. So this was a really big barrier. Multi-state licensure was another one. So there is no national licensure. There is a compact across many states, but we had to get each doctor has to be licensed in the state where the patient is at the time that the patient is being seen. So you can understand there that the challenge is you have to figure out where the patient is. We did that through mobile devices, through geolocation, but you also have to make sure that they're seeing a doctor who's licensed in that state, which meant we had to purchase licenses for multiple doctors across multiple states so that we had the right coverage so that we would be available to offer that on-demand service level that we wanted to. The other barrier was there was no reimbursement. So CMS did not offer payment. And in cases where health plans did pay for this, they often did not have payment, they really pretty much did not have payment parity. So we're not able to charge the same amount as we would be for an in-office visit. So there were a number of these types of challenges. And then also, if you were an individual practice, maybe a single provider practice, you had to take money out of your own pocket to input investment into even setting up your own telemedicine practice. And then the reality is you probably would not have seen enough patients to really justify that unless you had the multi-state licensure. So lots of different complexities to building out this type of practice. And then, as I said, there were professional skeptics. The AMA CEO accused telemedicine of being selling snake oil. So there were just a number of things I would say that that just showed a lack of understanding of what we were doing and the quality of care that could be provided. So I'm going to walk you through, this is a little bit of the timeline for Doctor on Demand. So we now have 98 million lives, but we had 98 million covered lives, but we had 0 covered lives in the beginning back in 2014. So the only way that we really could launch was direct to consumer, that D2C that I talked about. We started there, but then we very quickly became what's called B2B, meaning we were selling into health plans. So we didn't know this would happen so quickly, but health plans actually decided that they would cover some of the benefits at a lower cost than an in-office practice. So this created some traction for us and a bit of a track record. And so then we began to see patients coming to us for many different types of conditions. It wasn't just for, when we launched, it was mostly for low complexity care. But then people started showing up with mental health conditions. We very quickly launched our behavioral health practice. Patients were coming with chronic conditions. So then you end up with adding labs. And so you can kind of see how not just Doctor on Demand, but other telemedicine practices that existed at this time, we were seeing ourselves on a expanded scope of practice journey that eventually led us to an intersection with where we are today, which is really this current environment where we have a very disruptive global pandemic. And we had built the tools and the services to be able to offer a much more comprehensive set of clinical services that could mimic virtual primary care. And that's actually what we do now. So we just talked about this intersection with the global pandemic. This is where we are. I'll show you guys some more information about how this has played out so far, but this is probably the most disruptive thing that you and I and any of us really, I think, have ever seen in our careers. HIV is probably on some level close, but this really, in terms of disrupting even the flow of work through a large health system or a large hospital, I've just really never seen anything about this, and no one ever really talked about this level of disruption. Yes, in other people's lives, but never really seen this in the lives and workflow of doctors and other healthcare professionals. So we really had a stoppage of work, if you will, in healthcare delivery, and then we pushed a big reset button. But there's a lot of damage that has been done by this through those traditional practices that are brick and mortar. Those doctors went through a great deal of pain to have to adjust their practices, and I certainly I have a lot of empathy for that group because my father was a primary care physician. I think this is the kind of thing that probably would have damaged his practice and potentially even put him in the scenario where he had to close his practice. And we've seen many primary care physicians do exactly that and close down their practices or postpone their practices until the passing of COVID, until they feel that it's more safe to be able to practice one-on-one care in person. What we saw at the very beginning of the pandemic in the first few weeks was just this massive spike. So if you look there, you can see that in the middle of March, we had seen a 400% increase or 200% increase, in demand for services. And this was true of multiple different telemedicine vendors, about 154% increase in telemedicine visits across the 4 largest telemedicine providers in the country, of which Doctor on Demand was one of those. And so we actually published a paper on this earlier this year, just a few weeks ago with the CDC to really talk about the shift of where patients were getting care. Much of this has now gone back to, I'd say, like, if 80% of care was telemedicine during the height of the first wave of COVID, that went back down to about 20% being telemedicine for medical practices. Behavioral health, though, stayed closer to 80%. So really different. We're seeing really differentiated use of telemedicine services in response to the pandemic. I talked about those barriers back in 2013. I just left a few examples on the left side of the slide, but I wanted to give you some idea of what has changed since this global pandemic has set in. So since SARS-CoV-2, we've seen a removal of the originating site requirement. And that is a really big deal because what that means is Medicare recipients, Medicare Part B recipients, can now look at their Medicare benefits, and they can actually go into an application like a Doctor on Demand, and they can put in their Medicare number, and they will see that they now have eligibility, and they even may have a waived copay or the same copay that they would normally have for any other in-office visit. We also saw the public health emergency remove the requirement of state licensure. So, and they also made it much easier for doctors to get licenses in an expedited fashion across states. So, so if you're providing healthcare to a private insurer, a member or a patient who has private insurance, you could very easily get licenses in multiple states if you have a sponsor in that state. If you are treating Medicare patients primarily, then actually Medicare has enabled you to just with your single license be able to offer services through telemedicine to patients from almost any state. And then they also did some work on payment parity, as well as allowing voice visits to be reimbursed. So all of that right now is being reimbursed at the same rate as in-office visits. So that gave a great deal of incentive to practicing physicians who typically did not practice telemedicine to be able to offer telemedicine services for their patient populations. If you just think about what's possible here, just for a moment, and thinking about what's happened with this pandemic, but going forward, we were able to use telemedicine modalities in different ways. We were able to create risk assessments for patients. So with patients not having to go in, not having to use PPE, they could be assessed and triaged through these risk assessments. They could actually be proactively outreached to and given guidance, and also their symptoms could be checked. So a great deal of clinical work could actually be done during this pandemic virtually. The problem during the pandemic was the coordination that needed to take place prior to the pandemic between telemedicine and digital health capabilities and companies was not done. There was not coordination between those groups in the digital health group and then the traditional large health systems and standard practices. So practices that did absorb this well might have been examples like Kaiser or the VA or Intermountain Health, but certain health systems that had multiple sites that were the payer and the provider, they seem to do a bit better in their value-based care models to be able to respond to the global pandemic. So this introduces a lot of different, I think, potential badness, but also a lot of goodness. So there's been reports of fraud that has taken place with regards to telemedicine. So if you go to the FBI site, you'll see where there have been some people taking advantage of billing for visits that you would say, well, that was a very short visit and was just by phone. And so some maybe inappropriate or coding of types of visits. Our Stanford colleague, Dr. Randy Stafford, was a co-author on a paper that showed that traditional brick and mortar doctors in shifting to telemedicine may not have taken as many blood pressures as they would normally have taken for patients. So there were just questions about whether there was any difference or change in the quality of care that was being provided for patients with certain chronic conditions. Specifically, they called out high blood pressure in theirs. There's also been the emergence of online pharmacies, so patients being able to just get medications from a service and the doctor never sees the patient. It's not all bad though. I definitely would stress the part of the model that many of the telemedicine companies are using. They really are focusing on our more relationship-centered model, trying to provide a better patient experience. And we actually published a paper earlier this year in Mayo Clinic Proceedings that looked at patient responses and patient feedback on what they were seeing and what they enjoyed about virtual care. And the number one thing that patients did comment on was that they felt that they were establishing rapport with the clinician. So I thought that was very interesting feedback from the patients. And it was really addressing one of the major concerns that I had at the very outset 7.5 years ago was what happens to the doctor-patient relationship when the doctor and the patient are not in the same room? And the answer was that's the number one thing that patients actually like about it. So I think that's a really important insight, and it really does lend credence and value to the use of virtual care modalities and opportunities for our patients. And the last thing is, the use of these modalities and this technology, it reduces a lot of the social determinant barriers to certain populations within our communities. So some people may be single parenting, and working during regular work hours and don't have any access to healthcare other than an emergency room or an urgent care. And if they don't have proper insurance coverage, they're going to pay out of pocket significantly for that care. These modalities allow patients to have more access to asynchronous care. They also allow them to have access to care 24/7 without leaving their home. So as long as they have an internet connection or a Wi-Fi or a cellular connection, they actually can connect to a doctor remotely. Just a couple more slides here as we talk about this. I really think that we're at an inflection point at this point with telemedicine. It's really moved from being, sort of convenient type of care and techie and just easy, more like, getting an Uber and that kind of thing, more commoditized, to actually seeing longer term relationships build. Telemedicine is being able to see as a quality solution. It is lower cost, but also can deliver quality and can deliver a great patient experience. So moving from those low complexity issues, it now has the ability to do virtual primary care, more complex issues, more chronic disease management. So really a lot of different uses of these modalities. And they can even be used in really acute scenarios like tele-ICU and telestroke. And some of you may actually have some experience with those platforms. Last thing I'll just say is this last side that I think is a really, it's a really important thing, I think, not just for me, but many around the healthcare equity space of healthcare delivery. We at Doctor on Demand, we did not set out to, I'm just going to give you our use case with this, but I think there's potential to see equity amongst the workforce. And I think telemedicine may have some potential to bring that. We did not set out to recruit people of color to be the doctors in our practice. We did set out to create a diverse and inclusive work environment. And I think that was really important from the outset. 7.5 years ago, it's what we wanted to do. That's who our leadership was. And then what we ended up seeing was that doctors that came to us, they actually happened to be from these demographics of more maybe underrepresented groups. So our practice makeup is really interesting. And as I said, we did not design it to be this way, but I think we created an environment that did allow for this. So 75% of our physician workforce are women. 47% of our clinicians are Black, Indigenous, people of color, which is really outstanding and amazing. 21% of those doctors are Black, whereas about 5% of the doctors in the country are Black. So we have really strong representation across ethnic diversity, and then also 20% being LGBTQ. So our clinician workforce is a very diverse workforce, very representative workforce of the population of our country. And I don't want that to be lost as a potential benefit of telemedicine. The last thing I'll say is that these doctors are incredibly engaged in the practice. We survey them a couple times per year, and then typically they will range 95 to 100% engaged in the practice. And that actually ends up bringing up the average for our company. So it's a very high performing practice that can deliver quality. It's a very diverse and representative workforce. And I think that, I think that regardless of what we may end up doing post-COVID and as things return to normal, I definitely think we have earned the right and we actually really have a responsibility to look at telemedicine and digital health very closely and really examine what is valuable and what we should keep, and then what, and what was not as helpful. And so, it maybe shouldn't be reimbursed as highly. And I will stop there. Thank you.
Thank you, Ian. I really appreciate the talk, and we're going to take some questions from the audience here. I'm going to kind of curate them for you. And you talked about diversity in terms of the physicians and the clinicians delivering the care, but COVID really has, particularly with people who have homeschooling, has called attention to some of the discrepancies in access to computers and the internet with economically challenged homes. Have you seen that with virtual care, and what are the ways that your company or the industry is trying to address this?
This is a really great question. And there's no question that what I would say is this really is just a marker of the structural racism that really exists. And I think that we've all become more aware of in this country since the global pandemic. The digital redlining that's called is something that's already present. That's any I would say any disaster, any challenging time, any infectious disease, global pandemic that's going to occur is unfortunately going to disproportionately impact under-resourced communities. What we have seen, though, actually there was a paper that came out in I think the Journal of Medical Informatics Association. They actually saw that Black patients during the early COVID period were more likely to actually engage telemedicine than white patients. So this was a really interesting point. Now that's not equating to under-resourced Black patients to under-resourced neighborhoods, but I thought it was really interesting to see that data point. So we actually have seen a fairly diverse, more increased diversity of our normal patient population since COVID. That's not just an ethnic diversity, but we've actually seen more and broader diversity of age groups as well. So we're actually seeing, I think, if in a broad definition of vulnerable communities by age, by ethnicity, by race, by socioeconomic status, we've actually seen more diversity enter into our practice since COVID. So it's actually, So I think I don't disagree with the concern. There's no question that access to high-speed internet is more limited for certain communities. And I really actually think that that is one of those things that the infrastructure of our country and our policymakers, that's to me where that really should ultimately be addressed. The digital literacy that is required, that is something that I don't think we can put all of that on our doctors and our nurses who are actually the frontline workers and already doing so much work in response to this pandemic. We need our policymakers to lead and to step up and to write the policies that will actually provide these resources to the communities that need them. And then we are here to deliver the services that they need, but we can't build the infrastructure, do the technology, and provide the clinical services all by ourselves.
Okay. There's a couple of questions here around when you started out, there were licensing challenges because the authorities didn't really want telemedicine to happen before 2020. And it was harder to get insurance reimbursements. I think there are quite a few people that are asking questions about, do you think it'll become more restricted again after 2021? Or do you think, insurance companies will ratchet back on the reimbursements? What do you think will happen? Will they allow the industry to continue to grow? Or is there going to be something coming pulled back?
This is the question. And I love this question. So thank you to whoever asked this one. I don't know yet, but what I would say is they're not going to say they're going to ratchet it back yet because they can't, right? They literally cannot, which I think therein is the irony. Like, I would argue this should not even be a question at this point. Like, I think if you ask CMS, they will tell you that the genie is out of the bottle or the toothpaste is out of the tube. They'll say you can't, it's really hard to get that back in at this point because we clearly needed these services. And so why would you sequester them? Why would you bring them in when at this greatest time of need when they became so useful? Why would you try to lock all of that capability back up and remove these technical capabilities from the delivery? This is a healthcare delivery challenge, and telemedicine has enabled us to meet so much of that challenge. I just to be more specific though and answer parts of that question. I think some things will stay and some things will go. Video visits have been shown to actually do a nice approximation of in-person visits. So if I'm CMS and I have the data now, and I look at the claims and I look at which CMS or Medicare members ended up having to have another visit within 14 days after having a video visit versus having a telephone visit, and I saw that those two cohorts perform differently, I should probably keep one, and I should actually encourage one, and maybe I don't want to encourage the other, or maybe I will enable policy that that changes the reimbursement for those, because we want to really support high value healthcare, but we also want to offer patients multiple modalities to interact with healthcare. So my hope is that cooler heads will prevail, and that we will look and examine and study what the valuable pieces are of virtual care, and invest more in those, and then less in the others that we don't see value in. So I don't think it'll be, so I think it will move forward. And what I would say is we've moved forward 10 years probably already, and no amount of Super Bowl ads would have ever propelled telemedicine, evolution faster than the global pandemic. But I also realize that there's a lot of pain around the country with trying to make this adjustment. And so I think we'll slip back in terms of like parity for payment. I don't think they'll keep that. I absolutely think that'll go back to closer to where it was before.
So there's a question about, are there certain specialties that seem to be more conducive to this kind of medicine? And or on kind of the flip side, are there certain kinds of patients that seem to be more conducive to this kind of environment?
It's a really good question. I think I don't really think so. I don't want. First of all, I will say that I'm biased, but my early experience with telemedicine, I'll go back to my VA experience rather than talk about my current experience, because I don't want to be too commercial here. So even in my VA experience, we saw people using telemedicine in the tele-ICU, where the attendings would monitor the ICU from their homes. And that was mind blowing to me back in 2002. When I got to Stanford, I thought, wow, they can do that. And they had cameras in the rooms so that they could actually see the monitors and see the IV lines. in the room. So I think there is, there's a wide range or scope of practice for telemedicine, but it doesn't act on its own. It doesn't take care of the patients on its own. It really requires adoption by the doctor, and then also by and other clinicians, and then also by the patient, and most importantly, by the system that's supporting them, because the systems and the payers have to be able to incentivize the responsible delivery of that care. But I really don't think that there are patient population, I'll use it's really hard for me to think of a patient population that cannot benefit, other than maybe the youngest population that cannot communicate. But this is really, even if you pick almost any scenario, and we'd have to start going through scenarios for me to maybe we'll come up with some, but patients who lack mobility or have disabilities, patients who have mental health conditions like autism or anxiety, there's just, telemedicine might be even a better model for many of them, because our current healthcare system is not always equitable or accessible to them.
Okay.
And maybe I'll just say one more word about that as an approach. If you think about the history of telemedicine, telemedicine was started by people who were trying to deliver clinical services to patients who could not get to the health system. They could not make it to the hospital. They couldn't make it to the clinic. And so these early pioneers of telemedicine were trying to bring the care to the patients. And so you just have to remember that as the beginning. This was not always a commercial endeavor. This was really an access to care endeavor that health systems that had a responsibility to deliver care to remote patients started to engage telehealth modalities. And I think it's a really important thing to remember, because you want to be very careful about how you restrict it from different patient populations.
Okay. There's a question here about how secure is a virtual visit, and are there standards within the industry?
There is. This is a short answer. I'll just say there's a high trust accreditation, and there are other security accreditations, and they are the same types of level of PHI stewardship that hospitals may do. Actually, some hospitals don't even have high trust accreditation. If you think about, just to use this example, fax machines, if you use fax machines, it's hard to be high trust accredited, but you could actually make your healthcare data and personal health information much more secure in digital fashion if you become accredited with one of these security agencies. So it's very secure.
One person was talking about telemedicine not being much different than talking on the phone, because you can't touch, feel the patient, listen to their heartbeat, and so forth. So, that probably talks to, the potential intersection between virtual patient care and the use of wearable technologies or that sort of thing. So how do you, when you can't touch and feel and you're,
Yeah. Well, I should probably tell people what I used to teach when I was a more full-time faculty at Stanford. So I taught bedside medicine. Actually, I taught the second year advanced clinical skills course, which was a theme within the broader practice of medicine course. So I taught the second year students, if you'll recall, how to do a cardiac examination, how to recognize a murmur. So I love the physical exam. And so with video medicine, or as Jennifer mentioned, with those remote patient monitoring capabilities, actually we can really start to recreate the exam in different ways. You can provide ongoing monitoring of patients, but in the simplest form, for the synchronous, what we're doing face to face, the doctor can guide the patient, and the patient's hands actually become the doctor's hands, and the doctor will show them where to feel and how to feel for the lymph nodes, and ask for subjective reports of pain or swelling or warmth. And so you really can reproduce an exam very nicely, I think. And just to point people to the Mayo Clinic actually has begun to release videos and trainings on physical examination through telemedicine. I think it's really worth looking to see how they've been able to recreate much of the physical exam through these videos. And it's really a service that they've performed to share those with the public.
Well, building on that, the fact that Mayo Clinic is doing that, one of the question was, how do medical students start getting experience in digital health? Where will the next generation be learning this? Because right now it's not part of the curriculum.
Yeah, and I actually think that's that it should be. So I think that actually right out of Stanford, the Stanford Presence 5, Donna Zulman and Abraham Verghese have collaborated to create the Stanford Presence 5 with a very thoughtful panel. I'm saying that with a smile. They were kind enough to invite me to help as a telemedicine representative, but they also made a very nice group of telemedicine Stanford Presence 5. And if you think about the in-person brick and mortar version and the telemedicine version, they're actually just about the same, because when they thought about, well, what matters most for being present in the visit, they really found that that the most important things, and this was done by a Delphi panel that determined this, that that those things did not necessarily require that the same level of touch and presence in the exact same room. They all could apply virtually versus in person. I might have lost the thread of your question though. Did I catch it?
No, I think that was exactly, it was, how to learn it, and will they start be teaching it, and the fact that, the presence group, and for those who don't know about it at Stanford, is really looking at what is the most important thing about developing that relationship between patient and caregiver.
And that might be the most important thing to teach. And then otherwise, we are raising a entire generation or two of doctors who have grown up with the smartphone and with these modalities now. So they get into medical school and they have no recollection. They don't know anyone's phone number. They don't even know their parents' phone number, because they can just get that automatically on their device. So some parts of life are getting easier. But for those of us who came into a world where we had a rotary phone, and that's what I grew up with, we have to adapt a little bit to the world changing around us.
Will healthcare costs increase or decrease with more virtual care? Will I pay the same for a virtual visit as an office one? And we've got all these students on campus who are protesting their tuition because they're not having classes in person. So what's going to happen to costs? Is this going to help? Or is it going to be saying, well, you're using technology, it's going to cost you more?
This is also a great question. And again, thank you for whoever asked this one, because this starts to shake and rattle the cage of how healthcare and education is how we do it, right? I do think this will lower the cost, actually. Or another way to say that, let me qualify that by saying responsible, relationship-centered telemedicine will lower costs, actually, if that's what's done. But we already have models, and there was a paper in Health Affairs in 2017 that looked at phone-based visits and did not see that there were any savings. They saw that that the phone visits were additive. So even though they were cheaper, they really you had more of visits, and so they ended up being the same cost at the end of the year. And more visits, but it was just a combination of virtual visits by phone and then in-person visits. But that's not what we've seen with video visits. And so, and I don't want this to all be about video bad, good, phone bad. I actually think all the modalities can, if they're used responsibly, they can actually save on costs. The most important thing about that, though, and this is why it's a complex question, is that we have to change the payment models too. We can't just change and say, well, let's do more on telemedicine without taking care of how we reimburse it. And so I think a bigger movement towards capitated payment models, where there are bundled payments to the doctor, and then the doctor and patient can figure out the best modality for the care. That's really the way to approach it. So it should reduce costs, but also bring value. And even if it breaks even, but and adds additional value, I would say that's a win. That's a win for our healthcare system.
Some of the clinicians here, or one asking if you're hiring. The second is, but do some people have a traditional practice and maybe half-time that they're doing virtual, and are they doing hybrid models now?
Yeah, they are. And actually, I actually think this will be, I actually kind of hope that is the future of telemedicine, and we'll just call it healthcare delivery. And some of it's going to be virtual and some of it's going to be in person. But most of our employed doctors are actually full-time. So about 60% of them are full-time with us. And in the behavioral health practice, we are hiring in the behavioral health practice. And in that practice, those doctors are more hybrid. So more of them are sort of 50%. They move towards full-time once they engage with us, but they often enter our practice part-time and then sort of work their way up, learn more about telemedicine, and then say, oh, this is, they like it. And across the country right now, but most behavioral medicine doctors who have moved from, almost no telemedicine to 80% of their practice being on telemedicine or 100% on telemedicine, the behavioral health practices are still at about 80% telemedicine. So they've not gone back the same way that physical medicine doctors have. So I actually think, you can make a very productive career with telemedicine, and in some cases, the specialty may make a difference a bit there. If you're a proceduralist, obviously your procedures need to be done in person, but that doesn't mean you can't do a high percentage of your practice virtually, and then just rent or share that office space for the procedures with other subspecialists, endoscopists, and so on. And that may be a more efficient model for people.
And are there other types of providers? One of the questions was, do you have RNs or PAs or people who are in physical therapy or OT? Are they getting involved?
They are. Yeah, we do have an interdisciplinary practice. We have diabetes educators, social workers, master's level therapists, so LCSWs, nurse practitioners. We Doctor on Demand ourselves launched nurse practitioners and LCSWs this year. So we always kind of joked, well, we are Doctor on Demand, like we aren't we supposed to always be doctors, but really the answer is we are a physician-led practice, and that will not change. But to continue to deliver care when we talk about primary care shortages, and I showed one of the slides just showing the closure of practices and so on, we just don't have enough doctors, honestly, for one-on-one care. That's true in primary care, and that's also true in behavioral health. And so we have to have scalable models, and we have to expand outside of just board certified physicians to meet the need.
And then this is going to be our final question for Ian tonight. Since most of the audience happens to be alumni of the Stanford Medicine, tell us a little bit about how your training or the colleagues that you have met at Stanford, or your work at Stanford as part of both faculty and as a clinicians, how did those help you with your challenges of growing a company and exploring this new field of medicine? Yeah. What did you learn from Stanford?
Everything. I mean, honestly, I would say I was so inspired to be on that campus, and being able to walk across that campus or go to events and meet engineers, meet basic scientists, meet healthcare economists. I mean, the richness of that environment to think differently and to think outside of the box. I think Stanford, people say, well, who's the #1 medical school in the country? And I mean, Stanford is my answer every time when it comes to that, because of Stanford's ability to really cross-fertilize these different ideas. I also was so impressed and inspired by my friends who would take their knowledge base and then translate that to commercial enterprise, and I think that was also very impressive to me. And then also the work that I got to do with my friend and colleague Lars Osterberg at Stanford, who's one of the faculty there and started the Educators for Care group, and he was co-medical director with me of the Arbor Free Clinic. I think that we have a great profession, and I think that I learned at Stanford how to be able to balance both the social entrepreneurship and the ability to align one's social values with the professional work that you do, but also you can make that a really innovative and even profitable at times endeavor that I see the private sector of what I'm doing as really increasing access to care to all. We're just proving it through a private entity, but once this is all proven out, I think it actually will provide more equitable care across numerous populations, especially the underserved. And so that seed was all planted, I would say, with my time at Stanford. And I always see successful entrepreneurs or innovators at Stanford. And as soon as they've proven that they can do something, I see them quickly turning to say, well, and how do I make this more accessible to other people and more people and make it more equitable? And so all of that, I think, is part of the DNA of Stanford. And I'm so grateful that, to get to see that done in a very successful way, in a collaborative way.
Terrific.
Thank you.
Thank you. Once again, I want to thank Dr. Ian Tong for this evening's presentation. I hope a lot of you have a better understanding about telemedicine, the opportunities, the fact that, yes, it did take off tremendously well with COVID, but there is a future in this whole area as well. There will be a recording of today's seminar available on our website next week. And you'll also all be receiving a survey asking you about your experience in today's seminar so that we can make the future alumni to alumni programs even better for you. Please join us for our next alumni speaker, which will be on January 27th, when we have Dr. Yvonne Maldonado. She will present on curing COVID, the outlook for vaccines and therapeutics. And many of you know that Bonnie Maldonado has been very, very involved in the work, both here at Stanford around COVID-19 and with national studies and developments of vaccines and tracking the virus itself. Information can be found in the coming weeks on our website about that program and future programs at med.stanford.edu/alumni, or just search on your web for Stanford Medicine Alumni Association and our website will pop up. Once again, I want to thank Ian. He's always there for us when we reach out for him to help students, help our alumni, or be involved in anything with Stanford Medicine. We appreciate the work that he's doing and the audiences that he's reaching with his technology, and for being with us tonight to share his experiences with all of us. Thank you, everyone, and good night.
Thank you.